Good evening, everyone, and thank you for joining us. We'll be getting started with introductions in just a moment, so please make yourselves comfortable. Before we begin, a quick note about Q&A for those of you joining us live in the Zoom webinar. You should see a control in your Zoom interface labeled Q&A. Later on, you'll have the opportunity to use this control to submit typed questions to us, which Professor Mark Rush from the Center for International Education and Professor Jeremy Weissman of the Roger Mudd Center for Ethics will read out for our panelists to address. We appreciate your understanding as we ask that you refrain from submitting any questions until invited to do so by our panelists. Once again, we will be getting started after a short delay to allow more time for attendees to join the webinar. We thank you for your patience. Thank you, everyone, for your patience. At this time, I would like to turn things over to Professor Brian Murchison, Director of the Roger Mudd Center for Ethics and Charles S. Rowe Professor of Law at WNL, to give the introduction for tonight's guest speaker and topic. Please go ahead, Professor Murchison.
Welcome, everyone, on behalf of the Roger Mudd Center for Ethics and the Center for International Education at Washington and Lee. Before we start tonight, I want to say thank you to a member of our team, Amy Jarrett, who has done outstanding work for the Mudd Center this academic year and last. She will be leaving us to take another position in town, and we wish her the best, and we thank her for everything she has done as an administrative assistant and indeed as a public ambassador for the Mudd Center. Thank you very much, Amy. Keep watching our speakers as they participate. So tonight, we continue our year-long series on global ethics in the 21st century, challenges and opportunities. It's my privilege to introduce tonight's speaker, Dr. Jonathan Wortham, who heads the Outbreak Investigations Team in the Division of Tuberculosis Elimination at the Centers for Disease Control and Prevention in Atlanta. At CDC, he has investigated outbreaks of Legionnaire's disease, tuberculosis, Ebola, Zika, and COVID-19. He's one of ours. He graduated from WNL with a degree in chemistry, and he earned his MD at Baylor, where he also completed a pediatric residency. After his residency, he was awarded the Epidemic Intelligence Service Fellowship, which is an applied public health training program at the CDC. He's the author of numerous scientific manuscripts about various public health issues. And in addition to his CDC work, he practices pediatrics in urgent care settings in Atlanta. For Washington and Lee, he has served as a member of the Science Advisory Board and as a member of the WNL Shepherd Advisory Board. His title tonight is Ethical Problems in Public Health Practice. And Dr. Wortham, we're so pleased that you're here, and I'll turn it over now to you.
Thank you so much for that introduction. And it's a great honor to be part of this lecture series. I was really looking forward to visiting Lexington, which is one of my very favorite places, and to talking about public health and ethics in person with all of you. And even though that is not possible today, I'm really grateful for the opportunity that Zoom gives us to facilitate this discussion while physical distancing is necessary for our health and safety. But I look forward to being able to join you on campus sometime in the near future. But before I get started, I also need to remind you today that I'm speaking only on behalf of myself and not my employer. Okay. So I want to start this talk with a little bit of imagery. I want you to imagine that you're a healthcare provider taking care of a critically ill patient during a medical emergency at an urban hospital. Some of you might have had this experience, but for those of you who have not, imagine a real-life version of an emergency medical scene that you've seen in your favorite medical TV show. You all know the ones that I'm talking about. These are the scenes where a patient is deteriorating in front of your eyes. There's a certain anxiety in the room as the medical team works through the algorithms necessary to diagnose and quickly and appropriately treat the emergent conditions in this patient. You, the lead medical provider, are interpreting information, making decisions, and directing others who are implementing the life-sustaining measures necessary to keep this patient alive. The scene is very tense, and in addition to your team communicating indicators of the gravity of the situation, beeping from the devices that report critical measures of the patient's status are alerting you to abnormalities that must be corrected quickly in order for your patient to survive. Your years of medical training have taught you the science behind the decisions that you are making during this resuscitation, which medications and treatments to give and why. But what principles should guide your decision about caring for this critically ill patient? And should every patient get exactly the same care in the situation that I'm asking you to consider? In the United States, for about the past 50 years, 4 main principles have guided medical ethics, the interactions between healthcare providers and patients. These 4 principles are autonomy, beneficence, non-maleficence, and justice. Autonomy is each patient's right to make informed, uncoerced decisions. If, for example, this patient had been diagnosed with a terminal illness prior to entering your care, and after making an informed decision, had elected not to receive resuscitation, medical ethics might support a decision to provide comfort measures and let the patient peacefully expire rather than pursuing the aggressive resuscitation that I'm asking you to envision right now. Beneficence is another principle that includes a responsibility to act in this patient's best interest, to make this patient your most important priority when she needs you, to safeguard information about her condition, to respect her rights, and to provide skillful and appropriate care to her. The traditional medical ethics framework also values non-maleficence, a duty to avoid unnecessary harm related with medical treatment. This principle is best described by the common phrase, which is implied but not directly stated in the Hippocratic oath that physicians take: first do no harm. I'll share with you a short story that helped me learn and consider beneficence and non-maleficence in context. If you developed appendicitis while eating at a fast food restaurant with your friend who's a surgeon, beneficence, the responsibility to provide skillful, necessary care, might dictate that your friend would perform the surgery on site with his pocket knife. But non-maleficence, the responsibility to avoid unnecessary harm, would dictate that your friend perform the surgery in a nearby hospital where pain could be managed appropriately and the risk of infections could be mitigated, optimizing the chances for a successful procedure. Finally, justice or equity means that you'll fairly distribute scarce resources and make treatment decisions on the merits of the illness rather than ability to pay or patient demographic characteristics. For example, you wouldn't stop this patient's resuscitation because another wealthier patient wants to pay you to treat their non-emergent condition without delay. As you consider the implication that these principles have on your decisions, one of your colleagues shouts out that they have a pulse, which is an encouraging sign. In the medical TV shows, this is the point that the incessant beeping usually stops, the anxiety dissipates, and the medical care providers turn to other pressing matters. For you, in this scenario, it means that the acute medical emergency has subsided. While the patient is likely still critically ill, the patient's care will likely be transferred to an intensive care provider, and you will continue to manage other emergency conditions. For many, including myself until about 10 years ago, the concepts of health and medical care and the guiding principles behind them began and ended with interactions between healthcare providers and patients. Whether they are scenarios similar to the dramatic resuscitation scene that I've asked you to imagine, or more similar to routine interactions that all of us have with our primary medical care providers. While these concepts and principles generally serve us well for these patient-provider interactions, they don't always capture all of the considerations that are necessary to promote optimal health and medical care in our communities. There is much more to the resuscitation story that I've asked you to consider. The story of this resuscitation didn't begin in a busy urban hospital. It began in a small rural town in Guinea, similar to the one shown in this photograph. Several cases of fatal diarrheal disease occurred in residents of this town before capturing the attention of local public health officials in this remote area. Concerned about an outbreak, but not knowing what the etiology might be, these health officials issued a formal medical alert within 2 months of the first reported case of diarrheal disease. However, within 2 months of this alert, people in densely populated areas, including the capital city, Conakry, depicted on the top, began having fatal diarrheal disease, prompting attention from national and international public health partners. Shortly after that, the Pasteur Institute, a French organization, confirmed Ebola virus disease as the etiology, and an outbreak was declared by the World Health Organization. Despite these declarations, the outbreak quickly spread to the capitals of neighboring Sierra Leone and Liberia, depicted on the bottom right and bottom left respectively. While outbreaks of Ebola virus disease have been documented since the 70s, this is the first time that an outbreak spread from isolated rural communities into densely populated urban centers. But how does this relate to our original resuscitation? The resuscitation story was not purely made up. It's a compilation of the stories of 2 physicians that were relayed to me during my time assisting with the outbreak response in Sierra Leone. During that time, similar scenes were playing all across the 3 most affected countries. During the next 2 years, more than 28,000 cases of Ebola virus disease and more than 11,000 Ebola-related deaths would be reported in these 3 countries. The outbreak had devastating social and economic effects in these 3 countries. The direct economic cost of the epidemic has been estimated at more than $4.3 billion. An estimated 30,000 children became orphans, and nearly 8% of medical providers in Liberia, one of the 3 most affected countries, died from Ebola virus disease. And the toll was likely similar in Sierra Leone and Guinea. And many healthcare workers, including those whose stories inspired the resuscitation scene I've asked you to picture, succumbed to Ebola virus disease. Their colleagues often posted pictures of these heroes in the facilities after their unfortunate deaths. The patient-physician relationship is powerful, but it wasn't enough to protect these patients, healthcare providers, and societies from this deadly infectious disease. A broader societal response was needed. But what should this societal or public health response be? And what principles should guide the public health approach? And should they be the same principles that govern patient-healthcare provider interactions? Because most of us have encounters with medical providers, either in emergency or routine settings, it might have been easy for you to envision what the medical provider or healthcare provider does during the resuscitation scene. But many of us have relatively limited interactions with the public health system and might find it challenging to envision how public health should interact with society, or how it could have saved the lives of the healthcare provider I've asked you to envision, or his patient, her patient. So before we consider the question of which principles should guide these interactions, we'll briefly consider what public health does, or at least should be doing. Here is a graphical depiction of 10 essential public health activities, according to the American Public Health Association, which groups them into 3 areas: assessment, policy development, and assurance. Assessment includes 2 critical activities. The first, depicted in the dark red at the 12 o'clock position in your screen, is to assess and monitor population health. Infectious disease surveillance, devising and maintaining systems to collect and interpret key information about various diseases to understand their incidence and distribution in the population, is an important part of assessment and monitoring. The graphic on the right depicts how complex devising and maintaining such systems can be. Surveillance frequently involves the public health laboratory to confirm specific etiologic diagnosis, such as the specific virus that is causing diarrheal disease in the scenario that we're discussing. In the United States, public health surveillance data are often available on state and local health department websites, and even the CDC website. When surveillance systems are well designed, they can inform medical providers' diagnoses based on the frequency of certain conditions within their community. Robust surveillance also facilitates identification of outbreaks, situations where the incidence of disease exceeds that which is expected in a particular population. In the absence of robust public health surveillance, outbreak identification may occur after opportunities for containment have been missed. This was the case during the Ebola outbreak in West Africa that occurred between 2014 and 2016 and serves as the backdrops for our discussion thus far. Robust infectious disease surveillance also facilitates efforts to investigate, diagnose, and address health hazards and root causes, another key public health function depicted immediately to the right of assessment and monitoring. After identification of health hazards, such as outbreaks, public health must investigate to diagnose root causes. For example, as it relates to the outbreak that we're discussing right now, cultural norms in West Africa often dictated that one is to take care of sick relatives in the home rather than taking them to a hospital or healthcare facility. Funeral practices often involve washing bodies of deceased persons. These realities, combined with the relatively crowded living situations in some areas within the affected countries as the outbreak spread, necessitated careful implementation of key infection control practices to prevent spread of Ebola virus disease while respecting the cultural context. Applied public health also gathers data to inform initiatives to improve population health for communities. These efforts are formalized during policy development and implementation. Ideally, public health assessment leads to effective communications to inform and educate communities about ways to mitigate health threats. To do this, the public health entity will often need to strengthen, support, and mobilize communities and leverage relationship with key partners. During the Ebola outbreak that forms as the basis of our discussion thus far, public health partners and policymakers forged key partnerships with community leaders. Here is a quote from a religious leader who is imploring people to recognize tradition, but not at the expense of making others sick with a deadly disease. After recognizing public health threats through assessment and monitoring and building partnerships necessary for intervention, public health must create and implement plans to address the public health threat to ameliorate its effects on the population. This is taking place in all of our communities on a daily basis. From health inspections in restaurants to implementing standards for public swimming pools, public health at its best is constantly translating lessons learned from assessment and investigation into policies and plans to improve the health of the populations it serves. During the outbreak we're discussing, ensuring safe but dignified burials that respected cultural traditions while preventing the spread of Ebola virus disease was a key policy initiative to stop the spread. Teams such as the one depicted here ensured safe and dignified burials across the 3 affected countries. Aside from assessment and policy development, assurance of ongoing capacity for public health practice is also important. Ensuring equitable access to public health innovations, building a skilled and diverse workforce that is capable of responding to issues across a population, improving and innovating public health practice through evaluation, research, and quality improvement, and building and maintaining strong organizational infrastructure for public health are all important assurance activities. However, in the 3 countries most affected by the Ebola outbreak that we've discussed thus far, all of these key public health functions were severely limited by resources or human capital. Having discussed what public health should do to ensure the health of the community, we'll return to the question of what principles should guide the public health approach. While public health ethics is an evolving area of inquiry, some have just suggested 4 principles for public health ethics: interdependence, community trust, fundamentality, and justice or equity. Interdependence recognizes the responsibility to respect individual rights, consistent with the principle of autonomy for patient-provider interactions. Nonetheless, interdependence in a public health context also recognizes that the health of some often depends on the health of others, and that the good of society must sometimes be prioritized over individual interests. For example, public health authorities have the power to protect the community from infectious diseases through quarantine powers when contagious persons choose not to isolate themselves from the public. Although most public health authorities will generally go to great lengths to obtain cooperation from individuals rather than using this power. Interdependence also recognizes that public health threats often do not respect political boundaries. Therefore, the health of one country, region, or state can have profound effects on other countries, regions, states, or even the global community, whether through shared exposure to a health threat like an outbreak, or because of other consequences that follow health threats, such as economic damage. The multinational effort to rapidly enhance surveillance and laboratory capacity was an important part of the outbreak response to the Ebola outbreak that occurred during 2014 to 2016. Community trust recognizes the need to develop and maintain trust through communication, community participation, collaboration, transparency, keeping confidentiality, cultural appropriateness, and obtaining community consent for individuals. Community trust of the public health entity, whether a government organization or at times a non-governmental organization, facilitates individuals, groups, governments, and other entities to participation in its programs. This may take the form of providing data, abiding by recommendations, or following orders. We traditionally think of a community as our town, city, state, but for widespread public health threats where broad participation in mitigation measures is necessary, establishing a community trust that transitions political and social groups is necessary. And for some public health threats, it might be necessary to involve the entire world. Therefore, to address these public health threats, it might be necessary to expand the notion of what community really means. Fundamentality recognizes a need to stay focused on underlying and primary causes of disease, as well as key requirements for healthy communities. This means the public health entity must stay focused on public health and leave other things to other entities. Finally, justice or equity stipulates that public health should work to ensure that conditions necessary for good health are accessible to all, including populations that are often described as vulnerable. While we commonly think of justice as a concept that dictates our responsibilities to groups within our own country, such as persons experiencing homelessness or incarcerated persons, I think we also have to consider justice as it relates to health around the world. The 3 countries with the largest cases of Ebola had some of the highest poverty rates and least developed public health and healthcare systems in the world. For many, justice necessitated contributing to assist this vulnerable population with the outbreak response. In some ways, the principles of medical ethics, those that govern the relationship between healthcare providers and patients, the principles that you and I envisioned during the resuscitation scene, might appear to conflict with some of the principles that govern the relationships between public health entities and the communities or population they serve. When we thought of the resuscitation, we prioritized the autonomy of the patient to make informed decisions for herself. But the context behind the story prompted us to think about the principle of interdependence and some of the public health measures, such as quarantine, that would have sacrificed individuals' autonomy, but might have prevented the healthcare provider and her patient from succumbing to this deadly illness. Even more broadly, interdependence means that we must consider our role in the health of others in faraway lands. Similarly, the patient-provider relationship emphasizes beneficence, the responsibility to do right by the patient, whereas public health practice places high value on doing right by the community, which is an essential component to gaining public community trust. Non-maleficence, the responsibility to first do no harm, is fundamental to the patient-physician interactions, but it can be difficult to perform any public health interventions without inconveniencing or adversely affecting a single person in a community. Finally, patient-provider relationships focus on ensuring equity for individuals, whereas public health must prioritize justice and equity for population groups. So while on the surface, it appears that the ethical principles that guide patient-provider interactions and public health interactions with society are different, we can now see that the two systems complement each other. Public health needs information from patient-provider interactions to perform key functions such as infectious disease surveillance. And results of surveillance can help providers diagnose patients by knowing the most prevalent conditions in their community. Providers might provide the first suspicions of an outbreak to public health. The resulting public health investigations inform targeted communication to facilitate prompt diagnoses, implementation of infection prevention protocols, and even institution of systems to improve health outside of the traditional patient-provider interactions. Strong infectious disease surveillance might have identified the Ebola outbreak we've been discussing earlier, reducing the morbidity, mortality, and preventing economic and social damage that this outbreak inflicted on these societies. While implementation of assistance wasn't perfect, the outbreak subsided after healthcare providers, public health, and the community, balancing these ethical principles, implemented effective infection control practices. Having discussed some of the ethical principles, some ethical principles of patient-provider interactions between public health and the populations it serves, and considerations about the global community, I think we've missed one key component. What responsibilities do we have to each other? How should we balance seemingly contrasting principles like autonomy and interdependence during a public health emergency? And what do we owe each other? To examine these questions, let's think a bit about the current situation right now. As of January 24th, more than 25 million cases of COVID-19 had been reported to CDC. The daily case counts increased dramatically during October and November 2020, and were at some of the highest levels during November, December, and November and December of 2020, and perhaps during January of 2021 as well. As many of you know, most of those who are infected with SARS-CoV-2, the virus that causes COVID-19, develop only mild symptoms. And indeed, many, perhaps as many as 40%, are pre-symptomatic or asymptomatic. This prompted some to ask what the big deal was and question the infringement on autonomy. One of the big deals concerns hospitalizations. This graph depicts hospitalizations in a CDC surveillance system that examines roughly 10% of the US population. Notice that rates, cases, hospitalizations per 100,000 associated with COVID-19 are depicted on the y-axis and time on the x-axis. You'll notice that the shapes of the curves are roughly similar to the previous graph, which depicted the total numbers of cases. However, the absolute rates differ by age, evidence that the morbidity associated with this disease is not uniform with respect to age. Hospitalization rates are highest among those 65 years of age and older, and decrease with age from there. COVID-19 in our communities disproportionately affects older persons. This graph looks at hospitalization rates by race and ethnicity. Similar to age, you can see that disease-associated morbidity that results in hospitalization is not uniform with respect to race ethnicity. Adjusted by age, as these graphs are, as you can see, hospitalization rates among Hispanic or Latino persons, non-Hispanic, American Indian or Alaska Native persons, and non-Hispanic Black persons are more than 3 times higher than rates among non-Hispanic white persons. COVID-19 in our communities disproportionately affects racial and ethnic minorities. This map examines hospital capacity. Areas indicated by the darker shades are caring for a higher proportion of patients with COVID-19 within their inpatient units and intensive care units. Healthcare is not an unlimited resource. If there are no beds for patients or persons to staff those beds for patients, what happens to the person who has had the misfortune of having an automobile accident and needs an intensive care bed on short notice, but none are available? Or what about a person who needs a cardiac surgery after an unplanned heart attack, but the hospital is full? During times like these, it might help to view healthcare facilities in 2 ways. Sure, they should be places where we can access care in the context of the patient-provider relationship that we've considered before, but I think we all also must view them as community resources that have obligation to the broader community. While protecting our healthcare capacity is important, protecting lives is an important part of any ethical tradition. During this pandemic, more than 400,000 deaths have been reported to CDC. You'll notice that the shape of this graph is roughly similar to the one that depicted incidents. More COVID-19 deaths have been reported during recent weeks than at any point during this pandemic. This graph looks at deaths according to age on the right and cases according to age on the left. You'll notice that the proportion of cases is higher among younger people, and the proportion of deaths is higher among older people. To prevent deaths among older people, we need to reduce transmission in our communities. And therefore, we all must balance our autonomy with the interdependent nature of these infectious disease outbreaks. There are reasons for optimism, as well as some opportunities to improve. Here are some statistics published by the Pew Charitable Trust based on their surveys and the research that they do. 72% of persons surveyed would agree to share names of people they might have been in contact with which is one of the essential components of infectious disease investigations. And even more, 77% would share places that they have visited, which is another important part of investigations when patients are in places where they might not know the names of the people with whom they came in contact. Nonetheless, slightly fewer than half of Americans are comfortable with all three steps of contact investigation, which include speaking with a public health official, naming contacts, those are persons to whom they were exposed to while contagious, and quarantining if advised to do so. And among the 7% who indicated that they would probably or definitely not quarantine when asked to do so, a plurality said that they wouldn't do so, quote, because they don't think it's necessary. As contact tracing is a fundamental public health activity, not just for COVID-19, but for many other infectious diseases, and will be important as COVID-19 disease goes down so that we can deploy the vaccine in targeted ways to stop outbreaks. I hope these level of community trust improves. COVID-19 has had devastating impacts around the world. We've discussed some of the principles that should guide patient-provider interactions and compared them with considerations for public health systems during public health emergencies. We've also discussed the framework and responsibility that all of us have to each other for improving the health of our communities, and to expand that notion of what improving health means, as well as what our community is. Considering these principles will be important as we tackle the tough questions that the pandemic will continue to bring. Working together, similar to the Ebola virus outbreak, I believe that we will tackle this challenge as well. But we'll all need to commit and recommit to doing our part, because we're all a community, and at the end of the day, we're all in this together. Thank you very much for listening to my talk. I'm now open for questions.
Thank you, Dr. Wortham, for the extremely interesting and informative speech. So I'm Jeremy Weissman, and I'm gonna lead off the questions. And so just a reminder that questions are open, so please click on the Q&A and ask your questions, and we'll relay them over to Dr. Wortham. But for the time being, I'll go ahead and get us started. And I'm gonna start off just with a rather controversial question, just to, why not? So I saw a statistic today on the Virginia Department of Health, I think it was from the CDC website, that 60% of Virginians would currently be willing to take the vaccine when it becomes available. So hopefully there'll be more community trust and that number will go up, but let's say it remains 60%. It appears if that was anything like that nationwide, we wouldn't get to herd immunity. So people who have the vaccine might be protected. On the other hand, those who aren't vaccinated are spreading amongst themselves, and they could mutate it, right? That's everything in the news right now is the mutations. So while half of us or more might be vaccinated, those who aren't vaccinated might ultimately wind up undermining it for everyone, because they might lead to a mutation that makes the vaccines, unable to work. So my question is on the face of it, at least, given that situation, is there any case for mandatory vaccinations that would conflict with autonomy? But what about justice and interdependence for those who want to be safe from this COVID?
So I think that there's a couple of great points buried there. One is, I think, for example, we have to consider, we don't know whether the vaccine actually protects people from becoming contagious right now. We certainly hope it does. And I actually think the answer to that question, once data are available to support one way or the other, I think that will have profound effect, or it will inform the question of how and for whom to require vaccination. But there's no plan. I'm unaware of any group that plans to mandate vaccination. I think that there are a number of people, including close friends of mine, who were uncomfortable about the way, about how quickly the vaccine was developed. And I totally, and some of their concerns sound reasonable to me. These vaccines were developed really quickly. But I think when you look at how they were developed really quickly, why they were developed really quickly, and that the fact that no steps were skipped, and that the vaccines in general have been extraordinarily safe, I'm hopeful that more people will get on board and be willing to take the vaccine. More than 2 million people have been vaccinated so far, and there have been very few adverse events. Whereas millions of people have gotten COVID-19, and there's been many, many hospitalizations. And so I think that in sort of a risk calculation, I would implore people who are anxious about the vaccine to talk to healthcare providers, to talk to public health professionals, to hear about how the outlay of resources allowed us to study, conduct the vaccine trials faster than had been done in any other situation. And that steps weren't skipped. It's just that they were accelerated due to the gravity of this matter. And I would advise them to talk to their healthcare providers. And it's not a risk of vaccination compared to just not getting COVID-19, but the risk of vaccination and being protected from COVID-19 compared to the risk of becoming ill with COVID-19. And I think that, I think for many, many, many people, most people, the data are showing that the vaccine is very, very safe. And so I think that, we have a way we've got a ways to go as far as reassuring people and talking to them about the data and talking to them why we were capable of doing it this way. But I think that's, I'm hopeful that that's going to be an ongoing conversation between people, the healthcare system, and the public health system.
Thanks, Jonathan. I'm going to combine a couple of questions with one I received in anticipation of your talk. It was based on our discussion that we had with faculty fellows earlier this week. But following up on the question of trust in the science, establishing a trust among the population, can you draw upon your experience in your study of Ebola in Africa with regard, with regard to establishing trust there, and are there lessons or perhaps parallels you can draw between developing that sense of public trust with regard to treatment, vaccination, and so forth, and how we might establish that trust here in the United States with regard to COVID?
I think trust is one of those things that you have to build up over time. And I think that, and I'm really, as I've gotten the opportunity to meet public health and healthcare people across the country, it's been really nice to see how they've been interacting with their communities on a day-to-day basis, building up trust by doing things to make their communities' health better. And so I think that's one key component of getting community trust is people in general don't, they really care how much you care about them. And I think that was really key during the Ebola outbreak too, is to see people, people needed to understand that you cared about them, you cared about their cultural traditions, and then they were receptive to hear about, hey, we need to make some changes in the infection control regimens. And so how can we do that in a cultural context? And when people think that you care about them in general, sort of in my public health practice as well as my medical practice, that's where you start to sort of find the solutions that are going to be lasting and that people are going to implement on their own volition, and that people are going to encourage the people that they lead to do the same thing. And that's where the public health intervention is going to take a life of its own, is when you get people interested, and you do that by caring about them. I think that's where we're really going to start to see headway.
All right, so this next question, again, maybe somewhat controversial one coming from an audience, says, do you believe that Dr. Fauci's initial decision to downplay the importance of masks in order to secure a supply for healthcare workers was ethical, or do you believe he should have been honest from the start at risk of not having PPE available for healthcare workers?
So this is this is one of the hardest things about this pandemic is this disease. There's a number of differences between this disease and just about any other disease that has been around before. And I think that so one of the reasons that we didn't recommend masking before is because we didn't know that asymptomatic and pre-symptomatic people are some of the most contagious people. And so with traditional infectious diseases, where you're symptomatic before you can transmit to others, the symptomatic people wearing the masks makes a lot of sense because the masks help prevent them from spreading to others. However, when we started to discover that asymptomatic and pre-symptomatic spread is a major mode of spread, then we shifted to a model where we assumed everybody was infected. And that's why we wear a mask. Because my mask protects me in case protects you in case I'm contagious, and your mask protects me in case you're contagious. And so I would disagree with the characterization of Dr. Fauci as not being honest or ethical. I would say that given the information that we had at the time with respect to other viruses, he did the best that he could, and he relayed information that was consistent with the best knowledge at the time. However, science is an evolving process, and this is a new disease. And we found new information, and we made changes. And there'll likely be other changes. And that's part of public health, is making sure that you're consistently evaluating everything you're doing, and you're making changes for the better. And you're making changes to make public health interventions more effective and health and communities better.
I have numerous questions about trust, and you've done a great job touching upon them. So I'm going to shift to a couple of the other questions now that shift us off of the trust to other aspects of your points and the discussion generally about COVID. One concerns the ethical obligations of healthcare workers themselves who might be skeptical about the vaccine. And our audience member asks, well, on the one hand, they have an obligation to medical ethics, be transparent about their hesitancies, do no harm. On the other hand, they have an obligation to public health ethics, encourage the vaccine and so forth. How does the skeptical health worker then deal with sort of being torn in two different ethical directions?
Yeah, that's really very hard. And I think one of the considerations will have to be is one of the scientific questions that we'll have to answer is, does this vaccine protect you from spreading to other people? Right now, we don't know. The evidence right now is that the vaccine prevents you from getting, or prevents the recipient from getting sick with COVID-19. And so what if there is a vaccine? What if we get data that suggests that the vaccine protects you from becoming contagious? Then I think that will have to be considered. I think healthcare workers will have to consider that. However, there are ways that healthcare workers can work and prevent spreading to people without the vaccine, by participating in the mitigation measures, by wearing masks, by patients wearing masks. I myself have done healthcare works before I was vaccinated. And I took my best care to prevent transmission to patients, and my patients did the best they could to prevent transmission to me. And so I think that these are questions that we're going to have a lot more scientific data that will sort of feed into the public health ethics questions, such as I think one of the big ones is, does the vaccine prevent people from getting contagious? And we just don't know.
I guess there's one of the questions was on that point. Maybe it's a quick one, but it's just, do you have any sense of when we might be able to get an answer on whether the vaccine prevents transmission?
I don't know. But yeah, I don't know.
Maybe another one that's also just kind of quick. So this person says, at this point in the pandemic, healthcare providers must be facing an exhaustion unlike any other. Is there something beyond encouraging social distancing guidelines that people can do to help them?
Yeah, so I think that doing whatever you can to lower the incidence of disease in your community is really important, and I think is a great help to healthcare providers. One of my good friends who's an ICU physician that I talked to last week, she said she felt like somebody, the boy at the dike in Holland in that story, she felt like she was trying to put her fingers in all these holes, but somebody kept blasting a hole in the other part of the wall. And so I think that a lot of healthcare workers, including most of my close friends, are very weary right now because they're taking care of a massive load of patients, and they're having to give bad news to lots of family members, and they're having to see people in their healthcare facilities alone because of the infection risk. And that's all very sad. And I think hearing about people in my own sort of social circle who are very sick, I think it takes a toll on all of us. And so I think in these times, I think the other thing that we can do is, healthcare provider or not, I think we can find ways to stay connected. I think we can use the technology we can to stay connected to each other, because there's risk associated with loneliness, and there's other public health problems that have gone up in the context of physical distancing. And so I think us staying connected with each other, us maintaining that sense of community, is also a really important part of getting through this together, because on the other end, we'll want to be a strong community. And so maintaining those ties, I think, is really important, particularly for our healthcare workers who are facing what they're facing. But I think maintaining that community is really, really important.
A question now comes up, actually ties into a discussion we had last night. The audience member asks, how do you characterize the ethical principles that have guided the staging of the vaccine rollout in the US? That is, who gets it first, who gets it second, who gets it third?
Yeah, so there's a couple of different questions, and we talked about this today in Professor Chin's class too. So one question is, if we don't vaccinate the healthcare workers, for example, there's a chance that many of them will get sick with disease as they're going to be exposed to these patients taking care of them. And if we have lots of healthcare workers who are unable to work at any given time, it decreases the capacity of our healthcare system at a time where we need all that capacity. And so I think that's one consideration behind the vaccine. The next consideration, another consideration at least, is who has the most morbidity from disease. And that's going to be people with underlying medical conditions and people 65 years of age and older. And so there's another group that wants to maximize the vaccine for that group, because that group is at risk of complications, including hospitalization, severe morbidity, and death. There's another consideration that we want to decrease transmission in the communities. And for example, some of the initial outbreaks occurred in nursing homes and other long-term care facilities. And presumably, younger healthcare workers might have become sick with the virus, may have been pre-symptomatic, asymptomatic, or mildly symptomatic, and could have brought it into those facilities. And so vaccinating some of those workers and other essential workers who can't stay home and can't isolate themselves might be an important part, or probably is an important part, of preventing transmission in communities. And so I think there's multiple overlapping things that you want to do to ultimately reduce the level of COVID-19 in communities and across the country. And I think that state priorities have been focused on those different questions and different demographics in different areas, and sort of considering also the logistical principles about getting the vaccine getting the 2 current vaccines that require certain storage conditions, refrigeration at -70, and all of those types of things have to be considered. And so those are some of the considerations, ethical and logistical considerations that have to be made.
Just to follow up, came up in a discussion that we all had with the faculty fellows earlier this week. No matter what decision rule one comes up with, the CDC, whoever it is, whatever country, somewhere somebody's going to find grounds to rebut it or challenge it with regard to the distribution of the vaccine. And so is the government's only recourse in establishing trust then transparency, because somewhere somebody's going to criticize the decision rule?
Yeah, I mean, I think that there's there's challenge, and I'm speaking on behalf of myself. I think there's challenges anytime you're in a situation where there are multiple competing interests and all of them are valid. And so there's going to have to be choices made. And in the current situation, different states are making different choices to prioritize different groups relative to each other. And there's always going to be groups that would consider a different prioritization scheme. And there's always going to be good reasons. And so I think that we do have to be, exactly as you said, we have to be transparent, and we have to do what we say we're going to do as healthcare providers and public health practitioners. But I think I think that people should understand that a lot of these decisions aren't easy. It would be wonderful if we could deliver everybody their vaccine, they could put it under their tongue, and then we could be over this tomorrow. And I think that that's an important thing to realize, is that people are having to make really, really challenging decisions. And if this was a lot easier, we would all be super, super happy. And we wish we could get everybody what they needed right away. And I think that's one of the things that's one of the feelings that that people in medicine and public health, everybody sort of gets to this point where you feel like you're doing a little bit for the health of your patients or a little bit for your public health, and you feel like you're not doing enough. And I think that's where a lot of people, I think that's driving some of the feelings among healthcare providers, is we keep trying to do these things, yet it's never enough. And so we just have to do the best we can with the resources we have, and just know that all of us are working very hard, and we're going to try to find opportunities to improvement, and we're going to try to do as much as we can to get everybody protected from this thing so that we can move on.
So we probably have time for only one more question. There's a few in the queue on community trust, but since we've covered that to a fair degree, there's one on justice and equity that I thought might be good to bring up. This one says, how do we address the lack of data around social determinants of health in order to enable more just and equitable access to healthcare?
Yeah, so social determinants of health, that is, I think that that's an area that every public health and healthcare professional that I know, we would all like to sort of examine those, examine the impact of social determinants, and more, and even more, we'd like to sort of find ways to address those. And I think to do that, unfortunately, I know I have to go back to the community trust one, because I think one of the reasons that there's not a lot of data around social determinants of health is we just don't, is sometimes we're unable to get the data that we need to sort of examine those in a quantitative way. And so I think we have to commit to sort of establishing that community trust so we can get the data so that we can study those questions. And then we have to intervene to sort of ameliorate some of those, some of the health disparities, and work and act on that data. Because I know that I even have extended family who are don't want to participate in health studies because they don't think the data is going to be used to improve the lives of people like them. And so I think I think it's a big challenge. And I think it's something that we have to do. One other thing I want to say about social determinants of health and health disparities in general is I think that there's a lot of people who look at health disparities as something that we need to address because we care about racial ethnic minorities or the groups that are impacted by health disparities. And I think we should care about those, and I think that those are good things. But oftentimes looking at health disparities can help us identify other etiologies behind health concerns and actually provide lessons that can make our public health and healthcare interventions much more efficient. And so I think in some sense, we need to care about health disparities for addressing them, but I think we also need to care about health disparities because they prevent opportunities to make our public health and healthcare efforts more efficient, as well as opportunities to improve participation in other areas of our society, which makes our society stronger.
This brings us to a conclusion. We have a question from the audience. The audience member describes it as potentially a softball, but still points out that you mentioned that there are reasons for optimism regarding the development of the COVID-19 vaccine. So what do you suppose those are? And looking forward, what are the grounds for us to have optimism, promote the trust, and so on and so forth?
So I think there's a couple of reasons for optimism. Number one is we have these 2 vaccines. And to have vaccines in that short a period of time, and with the data we've had, over a couple million people vaccinated, to have this kind of safety data and 2 vaccines that in the trials were this effective, I think is fantastic. I mean, I think that I have a group of my medical school classmates that we meet over Zoom. We called it basically a holiday gift. These data were so encouraging. I think the other thing that's really encouraging to me is I've started to see more people participate in efforts to slow the spread. I see more people wearing masks, and I, invite everybody to wear a mask, but I've seen more people in this area wearing masks. I know that there are people who don't, but I've seen more of that. I've started to see businesses, which I know our business, I've seen businesses innovatively provide services and provide enjoyment to people in ways that maximize physical distancing. And I think that that's great news. And I think that I've seen places where our community is starting to work together to get over this all together. And so I think that all of those things are really give me a lot of hope.
On that hopeful note, I'm going to hand the mic back over to Professor Brian Murchison to carry us out. And thank you so much for an interesting and wonderful discussion.
Thanks, Jeremy. Dr. Wortham, I want to thank you. This has been an extremely informative program tonight. I can't thank you enough. There's so much food for thought. I could see us doing a whole program on, healthcare disparities at some future date. There's so much to be discussed and addressed there, and you touched on some of the real issues, and I appreciate that. I want to thank you also for spending a lot of time with Professor Chin's students this afternoon, and you'll be doing some more interaction tomorrow, and let me thank you in advance. Let me tell the audience that next Tuesday, the Mudd Center and the Center for International Education will sort of have a second program on ethics in a time of pandemic. Next Tuesday at 5, philosophy professor Aaron Taylor and local physician Ralph Caldroni will be talking about ethical issues involving COVID, so I encourage people to tune in for that as well. But really, Dr. Wortham, thank you so much, and for everything you're doing for everybody. And stay strong and stay healthy, and come back to us and talk to us again sometime in the future.
Thank you so much for having me. Appreciate it.
Thank you, and thanks to everybody who was on tonight. Again, stay healthy, and we'll see you at our next program.